authentic. Connected, structured, authentic, connected. I'm a good lad, structured, authentic.
Hello, everyone. This is Mark Chubahusky. Happy New Year. This is Align Health Insights, episode number 10, with my dear friend and colleague, Zsolt Kulcsar, who is VP of Digital at Emory Health System. Nice to see you for the first time this year, Zsolt. It's been a while.
It's good to see you, Mark, and a happy new year to you and all of your listeners as well.
Oh, thank you. I'm sure they will appreciate that. I mean, well, we're just getting right back into it here, Monday after a long break. So, look, I'll get just some preliminary questions just so my audience knows who we're dealing with here. Could you share a little bit about your background? I mean, look, and we have time here. So from your clinical days in primary care to acute care and rheumatology to all the way becoming VP of virtual health.
I'm happy to share my journey a little bit. You know, Mark, it's interesting because I would say there are four real phases in my life that are kind of have led up to where I am today. And I would break the first one up into a little bit post training. So when I really left medical school, I went off to do internal medicine. And the first time I left New York was when I got into this special program up in New Hampshire at Dartmouth, where you couple the rheumatology training with a public health degree and a little bit of quality improvement and really leadership development. So it was this time that I was exposed to telemedicine for the first time in my life. I've never heard of it. I didn't even know it existed. This was the early days before COVID, and that's where our department in rheumatology was dabbling with delivering telemedicine care across the state of New Hampshire and Vermont into rural communities.
Cool.
I thought this was the future. I really wanted to learn more, and I worked closely with both the telemedicine and rheumatology department to develop it. And then after that, I realized, New Hampshire is great, but it's a little too chilly for me and my family. So
Yep.
I went back to New York, and I took all these skills of telemedicine and applied them to my first real job after training, which was a rheumatologist at White Plains Hospital. Somebody who was forward thinking in the traditional kind of healthcare sense. And I wanted to deploy my new knowledge, not in just rheumatology, but telemedicine.
Mm-hmm.
I realized that, well, we didn't have the funds, the reimbursement was just not ripe, and this telemedicine care was just something that wasn't ready for the urban centers. So I had to go down and kind of work a little bit with a startup company in an incubator down the road from White Plains to even try some pilot programs. Because we weren't spending millions of dollars to just do a non-reimbursed visit and just to pilot things that were maybe are the future of healthcare.
Yeah.
I mean, I knew it was, but you obviously have to convince a lot of other people that this is the future. It took off nicely, and we were having some nice partnerships with the telemedicine company. I got to meet another dear friend of ours, Jonathan, and we had this huge idea of partnering with early startups and dabbling and trying new models of care is kind of a cool concept. So we started an accelerator program in our hospital and did that with a few other digital companies. But it was always still limited. It was one hospital. It was a hospital in a large system that was forward thinking, but was also a little bit restricted because they didn't have full access to the EMR data integration capabilities. And so I would say the third leg of my kind of pursuit of where I am now came when I was given the opportunity down in Southwest Florida to really build this on a whole system level. I always wanted to challenge myself to see if I could get this model of care going, for more than one hospital, for a bunch of clinics, integrate it right into the EMR and make it feel like a seamless product. And that's kind of what happened when I took my job as a system medical director down at Lee Health. I was able to build my second remote patient monitoring program, but I was really able to do it kind of large scale, system wide, and affect the whole community. And I think, during that time, I refined the model. I refined kind of how we do telemedicine in general. And then I landed in Emory just really 4 months ago. when I
Yeah.
was able to take on the role more on an enterprise level for an academic center, which I think is a little bit of a different challenge than a community-based hospital
For
system.
sure. Yeah. I didn't realize that. You've been, telemedicine's kind of been in your career for like a really long time, right?
Yeah.
Almost, since your academic training.
Yeah, I mean, it's interesting. Telemedicine's really been around for 20, 30 years.
Yeah.
And I give this fun little talk about, telemedicine and the history of it, but it started back in the 50s with radiology. And I jokingly tell people it started back in the Civil War when they were giving smoke signals and telegraphs were used to kind of bring in medical supplies because the platoon's low on certain, medical equipment and
Yeah.
splints and that kind of stuff. But obviously, it got really refined with the advent of the telephone, and then later on with like the IoT, right? The interconnected devices that speak to the web and speak to each other through technology like that.
Well, I mean, it really leads to my next question, right? It's like, for those who aren't as familiar with virtual health, what does like virtual health mean today? And like, how is it evolving beyond video calls? I mean, what's really interesting, we mark time to the Civil War. You're saying smoke signals for rations, or, to alert that you need a medic, right? To actual telehealth, to like, what is it evolving into, Zsolt?
Yeah, so I mean, virtual care is really that umbrella term. So when people think telemedicine is very specific. It's giving medical advice and care using telemedicine like video or audio technology. But virtual care is a much larger umbrella. So it's really taking digital tools, sensors, devices, wearables, and taking that information that it provides and actually using it to render healthcare, adjust lifestyle, coaching, and then also immediate interventions, medical interventions, right? So it encompasses all of that. But when I talk about virtual care, like the big umbrella terms that people think about are still just asynchronous video visits of just like a Zoom
Hmm.
call. You and I
Yeah.
are conversing, and we would maybe talk about medical issues, and then an opinion comes out and an intervention results. But you also have remote patient monitoring or remote therapeutic monitoring, which is collecting physiologic data from anywhere outside of a healthcare facility, just like a home, and then rendering care based on that. And then we have asynchronous technologies of I took a picture, I sent you a picture of my rash, what do you think it is? And you give me some treatment based off of it. And then a newer and more emerging area that's ever changing very rapidly is more of the wearables, right? So just taking all of the healthcare data that are telephone, smartwatch, mirrors, scales, all of these things produce, ingesting them and turning them into medical knowledge that we can use to help you get to your goals of health and prevention and not just really sick care. So it's really those four large areas that virtual care encompasses.
Yeah. Yeah. So now, like you said, you've been at Emory for 4 months. What's a day in your life look like? Balancing clinical insights with tech solutions like telemedicine and remote patient monitoring? I mean, it's probably more than that. What's it look like?
Yeah, it's interesting because when I started, it kind of there's an evolution. When you first start, everyone's like, "Wow, you're gonna like touch every single thing that we have going on here," and then it becomes more defined scope. And then as you start doing things, it actually again opens up like, "Holy cow, this encompasses a lot more."
Yeah.
And all aspects of our healthcare delivery really are touched by digital tools. But typical day is actually very typical for many healthcare administrators. You come in and there's day-to-day problems in our clinics. There's day-to-day problems our patients encounter in trying to get to a doctor, talk to a doctor, get clarification on their kind of prescriptions. And there's an administration suite built around all of those concerns to solve them, keep our clinics humming along comfortably. But really, what my day job is taking digital tools and kind of inserting them thoughtfully in solving some of these problems. So,
Yeah.
I live in Atlanta, or at least Emory is located in Atlanta. And while we don't have rural forests and snowstorms and that kind of stuff separating us from our patients. We have a lot of traffic. And
Sure.
people don't want to drive in just to get a 15-minute visit and an opinion from a rheumatologist, dermatologist, or whatever specialist you need.
Yeah.
They would love to just jump on a Zoom call from their home, enter some data, maybe give us some physiologic parameters, and be able to be managed fully remotely and only come in whenever they need a specialized test done to clarify and get them on the right path. So that's essentially, I take off the shelf tools within our EMR and then also look at vendors that can supplement the tools that are not in the EMR to be able to do that effectively for different specialties, not just primary care, but really the full scope of services.
Right. Right. Well, I won't ask you what specific tools because we don't want you to get inundated with LinkedIn messages. But look, you've got some hands-on experience in rheumatology. How has virtual health care changed for chronic conditions like that? Yeah, like I know remote patient monitoring we talked about, but I mean, beyond that.
Yeah, so rheumatology is basically the treatment of autoimmune conditions. So the big ones that people know of are lupus, rheumatoid arthritis, psoriatic arthritis, and unfortunately, our diseases are pretty brutal, and there's no cure for them. The best we can do today is to quiet the immune system and put it into remission, but we don't cure the diseases. We haven't cracked that code. So what that just really translates to is that people need to be monitored on an ongoing basis and longitudinally. So a lot of our relationships are 20, 30-year relationships. They're not 6 months, we treat you, cure you, and then off you go. And a lot of our medications are very risky medications. So they suppress the immune system, manipulate the immune system. And so as a result, we need to check in every 3 months with folks to make sure, one, their condition's stable and in remission, and two, that the medications aren't causing harm in the process. And so I was shocked to learn, rheumatology was always like the one field that is hands-on and cannot be replaced by technology. And I came to Emory and I learned my department here is one of the highest utilizers of telemedicine. A lot of other health systems, 5-10% utilization of telemedicine. In the rheumatology departments, 30% of our visits is via telemedicine. And it's really because of Atlanta traffic. People come from far flung places. The other thing is we are a specialized academic center. We have some experts that wrote the book on some of the diseases out there. And so people want access. And while they might be willing to drive down once to get a consultation, they would love to be managed remotely. And I think that's where telemedicine has opened up a world for us to be able to maintain longitudinal relationships that prior to then were very difficult.
Yeah, it's really the definition of that old quote, necessity is the mother of invention, right? I mean, but with that, right, I mean, because you guys have, or Emory has had to deal with this because of the traffic problem, and you're one of the higher utilizers of these technologies, you probably have a good bird's eye view into some of the game-changing trends you're seeing in telemedicine right now, like especially post-2025 policy shifts like Medicare extensions, right? If you can shed some light on that.
Yeah, so I think, ultimately it was interesting because we ran through this government shutdown and a lot of our flexibilities to do telemedicine. One of the big ones is to render care in the home. If these would not have been extended, we would have gone back to 1997 rules where you literally, patients have to go into remote clinics and be seen by a doctor in a clinic as well. So clinic to clinic approach. So these flexibilities being extended were huge. And, it just essentially told us that people want this, right? I mean, I had to make a tough decision of when the flexibilities expired. We had to tell people, okay, do we bring you back in person? Or do we just kind of bite the bullet and we assume telemedicine's here to stay? We're going to continue these visits. And we did the latter. And for several reasons, we learned that we don't have enough physical space to bring all the clinicians and patients back together in person again, right? We've designed models of care that actually harness the capability of our docs being at home 1 day a week and being able to treat patients in their home as well. So we don't have physical space to deliver all the care that we should be. Um, that was one really eye-opening and interesting thing that happened in the last few weeks. But then the kind of the future state of these things is, do we always need a video visit to be able to render good, proper, and like high quality care, let's say in rheumatology or other spaces? But what we've also learned is, just like you and I don't need to FaceTime every time we want to communicate, sometimes we get text message, sometimes we phone call, and sometimes we'd love to do a video chat.
Sure.
Our patients are the same way. And there are really neat tools that are, we call asynchronous tools, so e-visits, and then just self-guided, help tools of, this is your condition, this is what you should be doing, this is the exercise, the food that will make it better. People can self-manage. Sometimes they want to interact a little bit, but not necessarily via video with their clinical team. There are tools for that, like an e-visit. And then there are more advanced tools where I actually need data from you, and a scale and a blood pressure cuff and physiologic data, so remote patient monitoring. Those are kind of the layers of support we can all provide now in the home because the technology's there. And then the future is essentially putting a layer of artificial intelligence in between us and the patient. So we don't need to be involved in all of those conversations, but the artificial intelligence can be an intermediary. When we could be what I call the human in the loop, right? So there's a time when we need to step in, we need to make a decision, we need to course correct. And I think that's the exciting future of really digital health, right? Having this in-between layer of artificial intelligence and even just simple automation, if it's not even AI, but just some automation tools that keep people healthy, happy, and then surface when they're no longer that way and help us get involved.
Makes a ton of sense. So remote patient monitoring has been a big part of your expertise. Can you share an example of how it's improving patient journeys? I think you just kind of did, right? I mean, but for folks, say with, ongoing health issues, I mean,
Sure.
Yeah.
So, RPM, remote patient monitoring, is a very exciting kind of approach to treating people in their home. You essentially basically send a kit, and the kit has several capabilities. Sometimes all you need is a blood pressure cuff. Sometimes you need a little bit more, like blood pressure cuff, scale, and an oxygen sensor. People engage with these devices daily, and then essentially, based on critical alerts, if they're doing good, we leave them alone. If they're not doing good, we have people that are actively monitoring it on the healthcare side, and a nurse or a clinician jumps in and helps guide you if you're exacerbating a condition. So heart failure is a really good, kind of excellent example of this, where it's a condition that's usually chronic, slowly gets worse over time, and it's your body's inability to handle fluid. And it ends up on your lung and your legs in the wrong places because your heart is a little weaker. And the way we treat it is we give you a little water pill occasionally that takes off that excess fluid, so you're comfortable, you're breathing comfortably, and you could kind of do your activities of daily living. And with RPM, we're able to see small changes and intervene before you end up in the hospital fully decompensated with an exacerbation. And that's kind of what we were doing in Florida, where there was a lot of heart failure patients, because it's something that kind of is more common when you get a little older.
Yeah, my grandmom had CHF, so we had to take her to the hospital a few times because she was just full of water, right? And then we ended up getting her on Jardins because of the cardiac ejection fraction being below a certain percentage. But yeah, very familiar. That's great. That's a really great thing, because we could have certainly benefited. She could have benefited from that, because it's really scary. Because when you start filling up with the water, there's all sorts of these other symptoms that, nerve pain, as an example. As an active advisor to digital health startups focused on this virtual first delivery, what does virtual first mean And why is it such a hot topic right now for startups?
Yeah, virtual first is interesting because it was, I would even say, a hotter topic a few years ago. And now it's just becoming routine care.
Yeah.
Virtual first to me is, whenever you need help, the first thing you don't do is you jump in the car and drive to brick and mortar. That used to
Yeah.
be the old way of healthcare.
Yeah.
Now you're able to go on your smartphone and see what options do I have to assess where I should go. So virtual first startups, some people focus on kind of symptom triage and telling you that based on the symptoms you're experiencing now, these are the 4 or 5 ways you could get care, and this would be the easiest. So, like, let's say heart failure exacerbation, right? I'm starting to feel a little short of breath. My oxygen level's a little low. This might feel like an exacerbation. What do I do? Do I go to an emergency room? Is there a kind of an easier place I can go? Virtual first would be that I can go into my smartphone, go into like the EMR app that might have a symptom checker, plug in my symptoms, and it could tell you, hey, you actually can text message with a doctor or a nurse on the heart failure team, and they could probably give you some care right in the home. You don't need to get in the car. You
Hmm.
don't need to really go through that whole fiasco. Um, but sometimes your symptoms are a little bit more advanced, and they would tell you, well, we could still get a heart failure specialist and speak to you over a video chat. Or no, you're kind of really in a bad shape. You really should come in and be touched physically, and you need some
Hmm.
IV intervention. So that's what really virtual
Yeah.
first is. And there are companies that could develop every single step within that kind of scenario I just spoke to you about. So they needed advice on how do you symptom triage, or how do you build that e-visit module? How do you build the good telemedicine platform or RPM platform? And then also, if I did all that engagement with you in the home, how do I not lose that information so that when you drive into the ER, the doctor already knows you did all of that and you entered all these symptoms, and you have this kind of O2 sat reading from your house to make it a quicker decision when you show up.
Yeah, for sure. Okay, on the venture capital side, how do you spot promising investments in healthcare technology? Um, yeah, I mean, like, what are you looking for? How are you assessing companies?
Yeah, so it's really interesting. Obviously, there are some disease states that are chronic, they're prevalent, they're persistent, they're a continuous headache for health systems, for clinics, for doctors. So a company that really figures out the pain points that we have and builds proper solutions around those pain points always capture our attention, right? So you have to be really solving a true problem,
Hmm.
instead of building a cool technology in search of a problem. And
Sure.
this is almost like cliche at this point and overstated, but you want to make sure that whatever you build is truly solving a problem. And then you also want to make sure that it's financially sustainable. So that those are a few of the things that I look for. Is it a real problem? Is it something that I hear my colleagues constantly complain about? Is there something there? But more importantly, I also look at the team. So these digital health companies, you want to make sure that they have a team that is not just has great technology in their lap, but can really kind of run with it, adapt to the local needs of the health systems they work with, and be able to deliver kind of the outcome that they promise. So
Yeah,
it's
for
really
sure.
both.
Yeah. So team and actual real unmet need.
Yeah. And I know you're a talent search guy, so you're all about building teams and understanding folks, how are they going to be able to deliver on the promise of that technology. So that's also why we love partnering with people who have a good eye for this stuff and have been
Yeah.
doing it for a while.
Yeah. I mean, on a note there, I think culture is really important with these startups, right? And it's very rare, but every now and again, I just see this like unbelievable culture, and those companies usually win.
Oh yeah, yeah.
Um,
You
it,
attract good talent to a good culture, right? I don't know which one comes first, but it seems to how somehow suck in the right talent if you have a good culture and people enjoy working there.
It's culture. It's the ability to implement. It's the ability to survive sales and execution risk. It's the ability to align with the customer stakeholder, right? And from there, you usually see a high percentage renewal rate on the technology.
Yeah, absolutely.
So those are those are the things. There's probably more, but those are like some of the top things. So look, we all know this. Like, there's major workforce shortages hitting healthcare, and that's going to continue for probably a long time. I think we're going to be like 100,000 docs short by 2030, right? Something like that.
Oh,
How
yeah.
can virtual health and AI help fill those gaps?
So, if you know me and hung out with me long enough, the one thing I always say is digital is the workforce multiplier, right?
Yeah.
So we look at AI tools just in nurse triage, AI tools in simple triage of certain conditions. What human can do more than 15 to 20 interactions? We run nursing pools, and we realize that there's only so much a nurse can do in a certain day, and artificial intelligence can do that same thing and deliver it to 200,000 people at the same minute, right?
Yeah.
Now you worry about those people if they need escalation and they need a human in the loop. Can we have enough humans to kind of backfill all of the escalations? But that's what I think artificial intelligence and digital tools, in essence, provide. I mean, they provide more touch points. They provide low touch points to high touch points, and then they kind of pass the buck to the person in the loop when it's necessary, right? And I think the companies that really build it well try to reduce the need for that human in the loop until it's absolutely necessary. The companies that don't really understand healthcare, don't understand healthcare processes, physiologic processes, those are the ones that kind of fail doing that. They fail recognizing when there's an emergency, they fail recognizing when they could do more, and they kind of stumble and try to get somebody in the loop that you have to repeat and redo a lot of that work. So, I think, again, digital workforce multiplier, that's what digital tools and artificial intelligence are promising to do.
Yeah, for sure. When it comes to challenges in adopting digital health solutions, data privacy, tech access in rural areas, what hurdles are you seeing, and how can some of these startup companies start tackling some of those?
Yeah, I mean, there's quite a bit of challenges. I would say one of the bigger challenges is that if you have a great solution, you want to be able to speak to where the data is, which is the electronic health record. And it's the number one question that every startup gets asked is, how well do you integrate into my electronic health record? And when we mean by integrate is, how well can you take what you do, extract the data that I have, marry the two together, and work seamlessly, right? It's just essentially a data transfer. So data governance on the health system side, and then data interoperability on the startup side is kind of a key to success. And the more frictionless that becomes, the easier it is to adapt the tool. The other thing is actually startups and all of these companies understanding workflows. So where I see a lot of digital companies fail is that they build something and then they want the clinicians to adapt to a new workflow, as opposed to building something that seamlessly works in the workflow that we are naturally working in, right? So that's where there's a lot of education, there's a lot of hand-holding, and the less you have to do with that, the easier it is. I think a really good example is, all these artificial scribe tools.
Yep.
They do a really good job they've learned the clinician workflow. They integrate really seamlessly into the EMR. And as a result, it was very easy to just adopt these tools. Almost like I don't even know how many health systems out there are existing that don't use some form of artificial scribing. And it's something that is like 2 years old of a technology. If you think about it, you've never seen that rapid adoption with any other digital tool except for digital scribes.
Yeah. The time to adoption has been pretty quick for those, but there's, I guess, what, 151 automation use cases across healthcare and life sciences, according to Travis May from Shaper Capital, right? And some are getting more pull from the market than others. I think we've seen this kind of phenomenon, though, of larger systems like Intermountain, as an example, adopting some of these automation technologies much faster than we've ever seen before. This isn't a question that I asked you to prepare, but do you think that's a phenomenon that is going to end soon? Or do you think that we're going to see a lot of more, I guess, years and automation technologies getting adopted at a much faster rate? Like, just to close it, 12 to 18 month potential enterprise level sales cycle with a health system, maybe longer. Are we going to see those sales cycles shrinking because of these? I don't know. Yeah, that's my question.
I personally think that we will see those cycles close for the simple reason that we have to, right? The companies are really good at kind of bringing new products to life, and they're not going to be able to waste 3-4 years dabbling, trying to integrate and get some small pilots going. It's going to be a requirement that you'd be able to build something that's deployable and moves fast. And a lot of these scribe companies have been a really good, test of change. So it's changed how new companies have to think about it. I think the other thing is it's changed how companies have to think about their partnership with the EMR company.
I was just thinking the same thing, man. Right? Like, look what happened with Abridge, man. I mean, that was like, yeah.
Abridge was able to get on the BFF list for Epic, and as a result, it was like a rapid, cycle improvement. They didn't have to go to each single health system and be like jockeyed into a relationship with Epic. We want them, you want them, let's get it done. And then, 2 years later, you have like your first pilot case. Is basically Abridge got into bed with Epic. They made it easy. And then it was a tool that you could just pick off the shelf and use tomorrow, right? And I think that's the kind of relationship building that's going to have to evolve. It's a scary one, right? So startups, like, how do you get on that BFF list with Epic?
Well, yeah, because in the same sentence, right, then Epic goes ahead and launches their own ambient technology, the year after, right? Or 2 years after, right? So, I mean, look, you know better than I do, but a lot of these companies, what they do is they specifically choose one EHR to go after, right? And they'll say, okay, well, Abridge is, an Epic partner. We're Suki. Let's go for, Cerner or wherever they went. And then the other one goes for Athena, Anyway, very interesting. Okay. So looking at 2026 trends, how do you think telehealth will integrate more with things like wearables and home-based care? I know this has been going on for a few years now, but now we have this agentic AI layer, that we've been talking about, so what are like the newest, latest and greatest things there?
Yeah, I mean, I think there's a couple of things that we'll probably end up seeing. One is that the home is the place to be. I think the one thing we'll have to wait and see is hospital at home. It's been dabbling. The thing is the hospital at home the model that's going to win? I'm not 100% sure. In the past, I would have said yes.
Because if we look at like the reimbursement on the disease management algos, it's been terrible, right? So right. So I don't know that that's going to be the one.
I actually think more of like artificial intelligence is going to learn a little bit more about Mark, is going to learn about what Mark's needs are. Is it wellness, prevention? Is it that he has a chronic disease and that he needs to kind of engage in X, Y, and Z technology? And then artificial intelligence will recommend what we give you, how we engage with you, learn about you, and then teach us how to better serve you. So I think there's going to be a lot in the home. The data that your home produces and creates, we will want to have access to. And then we're going to want to give you, I think it's more passive type tools. So we put this in your home. It learns about you. It teaches us how we can better serve you, what condition you have. And then we will kind of engage you in your home, but figure out when you need to come into one of our facilities. But we're not going to deliver a whole hospital suite out to your house because that's overkill and it's probably not what you need.
Yeah, no, I agree 100%. Okay, as an advisor, what advice would you give to some of these early stage founders building virtual health startups? Fundraising tips, scaling tips?
Yeah, I think what you really, really need to understand medical workflows. So every single company I work with, they have great ideas, and I think I'm just blown away by how creative a lot of these young startup leaders are. They think outside the box, they think big, they have awesome ideas, but then again, they don't know how to apply them medically. And I think
Yeah,
just having that medical partnership, one is if you have the expertise on your team, even better. Sometimes you just can't afford to have a doctor or a nurse or clinical officer. But then that's where having the right strategic partnership with a health system, a clinic, where you have somebody who's willing to give that expertise in order to get some of your services. I think really just figuring out like how can you refine that clinical model. Abridge is a good example, right? I mean, they had to learn how to like take the documentation templates, how to deploy them, how to do that for doctors, how to do it for different types of specialties, different types of clinicians like nurses versus doctors. And so that takes a lot of medical expertise, and it takes a continuous frictionless relationship that's iterative. So one is building partnerships, building long lasting partnerships, because you will need those clinical leaders to be willing to engage with you more than once, twice, or three times. It needs to be an ongoing relationship. So, one is while you're out there trying to sell, figure out what you really need as a company. So, don't try to be everything for everyone, right? Like, try to go and snag strategic partnerships where you think you have something to gain, but you have something to give them too. And then, make sure you're comfortable with the teams you're working with, and don't waste your time somewhere that, even though it's a big name, if they're not going to give you the data, the expertise, the feedback to grow as a company, you're just going to be stuck with piloting forever. So it's a long answer, but I think just be smart about who you get in bed with. It's just like
yeah,
a marriage, right? You don't just jump into bed with the first person you meet. At least you don't get married to that person. So I think as a startup, you want to be careful about what you want to do, where you want to be, and kind of what kind of strategic partnerships you want to have.
yeah. Before I segue into social determinants, the individual plans in the Affordable Care Act went up the premiums on average this year by 26%. Employee plans were about 5 to 6% increase. The reason for the ACA plans going up so high, primary driver was the expiration of the enhanced premium tax credits through COVID. Look, and I'm just thinking about this context of virtual. Like healthcare insurance is literally becoming more and more unaffordable. I think I saw Wendell Potter speak, and since like 2014, when the ACA was enacted, I think health insurance for the average American family of four is $27,000. The average, with the average max out of pocket deductible, I think it hits like 51K, right? I mean, it's hockey sticking,
Yeah.
right? So where are people going to go? I mean, in the context of virtual, what's popping up to start really giving alternative payment models to health insurance?
I mean, listen, as a physician myself, I see this, and even my deductibles, at least while I was down in my health system in Florida, I realized that I lived a little further outside of the health system, so I was no
Yeah,
longer in network. And every time I showed up to even an urgent care, it was expensive to get a strep throat treated for my children. So what did I go to, right? This is a very
yeah,
personal example. I went to a company called Blueberry Pediatrics and essentially paid $180 a year. I got a home kit and access to text message, phone call, or video chat, a board certified pediatrician, and they were my first layer of protection. And if they felt like I need to go and get a test done in a brick and mortar, that was the only time I would go. Where previously I would be like, let's just swing by the urgent care,
yeah,
let's get a swab, rule it out. But when you get a $250 bill for each one of those visits, you want to make sure you need that test, right?
yeah,
So that's where I think virtual, digital, asynchronous, and sometimes not even a clinician, but just some type of guidance tool. Like, I'm not promoting Chat GPT, but we see a lot of use of it because of that, right? Like, do I really need this test? Do I really need to go into brick and mortar? Because when I do, it's going to cost me, right? So
Yep.
now, like, you just want better advice of when to go and why to go. And you want to do a little bit of research before you get there.
Because the majority of these plans are high deductible plans
Yeah.
as is. So yeah, it makes total sense. Okay, so how do social determinants like housing and access to technology play into virtual health strategies for better equity?
Well, I think social determinants are a major driver. Again, I look at just simple Atlanta, right? If I have to drive in, pay $15 for parking at Emory, wait an hour to go upstairs for a 15-minute visit, um, I will think twice about it how many times I do a follow up with my rheumatologist. And if I could do a telemedicine every other time, and it's going to cost me no gas money, no parking fee, no headache waiting for the doctor, and I get the
Yeah.
same outcome, of course I'm going to do it. Now that's assuming the patient has an internet and a smartphone, right?
Yeah.
So we have to start thinking about people that don't even have access to digital technologies. The good news is a lot of our cities are a little bit better wired than rural, but that's where we really need to be thinking. Like, digital is clearly lower cost, easier access, and makes things more convenient. But some people are not even able to harness that capability. But do we have centers where you could check in and do a quick virtual remote consultation, but still only go to your local area, your local center near you, as opposed to kind of really take this huge commute and commitment away from work to get care.
Yeah.
So those are the kind of things that we're being constantly asked by the government and are asking ourselves is we should be assessing what the limitations and needs are of each individual patient. And then, some of, like, if we go to the high end, some of these newer homes and apartments, they're coming fully wired. I was always fascinated by this community called Babcock Ranch down in Florida, which is touted as one of the most futuristic developments and communities in the country. Hurricanes came by, they were on their own solar grid, nothing went down, no flooding, no damage to the home, and every home's a smart home. They have a smart lock, smart garage door opener, smart doorbell. They're wired fully with internet. So to get remote and digital care from our local health system, which we were, it was the easiest to beam in and do care there. So, I think,
Wow.
thinking of how do we build the future, even homes, they're going to enable or disable healthcare.
Yeah, for sure. Okay, for aspiring pros in digital health, what skills should they build? Clinical knowledge, tech savvy, something else? What is that blend of skills that these startups should be thinking about putting on their teams to make sure that they have that, uh, you know, that it factor when they're trying to get enterprise level contracts?
Yeah, I think one is just understanding really what you're going to be solving, what problem you're solving, and there's no better place to test it than on your family. I mean, if your family doesn't get it, our patients won't get it, right?
For
So
sure.
making sure, like, if you're building a digital tool for 80-year-olds, that they're able to get on, it's easy. So that's number one. It's got to be easy and simple to use. Number two, again, I just think always being on the lookout and kind of moving in those circles of people that you have expertise, right? Like, sometimes you just have to listen a little bit more, like really understand the pain points of people, not just try to recreate and bring other people into your workflows that you thought would be awesome. And maybe not even committing so hard in the beginning, but sitting down and understanding your problem a little bit better, taking a little bit longer to fully understand the problem you're trying to solve. I think if you do that well, the customers and the revenue will follow. Right? That's the only thing I've noticed. Like, the easy, good, awesome technologies that I've seen out there, we wanted more of it, right? Like, as soon as we start touching it, you realize you want more of it. You want to expand it to all your clinicians, and it's a no-brainer. And the ones that, were not built right, we're constantly going back and saying, well, how can we use this? How can we improve it? And what you realize is you're always trying to convince your colleagues to use something that just is unusable. So I think really understanding who your market is, what you're trying to solve, and making sure that it fits into medical workflows. And if it doesn't fit into medical workflows, you should at least be improving the workflows, not making it harder for your technology to use.
Yeah.
And Mark, I know you have many friends that are nurses, but in healthcare, one of the biggest things we do as physicians, and I was guilty of this in the past, is this is really cool. I think it's going to help my patients. That's what I say as a physician. And then I dump it into my nurses to fix and figure out how to operationalize something. Because nurses are very resilient. They're at the bedside. They're constantly with patients. But, we have to stop doing that to our nurse partners. We really need to think and be partners with them if we're going to change healthcare delivery.
My fiance is an OR nurse at an academic medical center, and she thanks you.
Yeah, my sister-in-law is a pediatric ICU nurse, and she constantly tells me, like doctors they're like, oh, go use this thing, and they walk away, and then they're trying to figure out how to like improve healthcare with that new tool, and sometimes you just simply can't. But the nurses are resilient. If there's a way, they will figure out how.
The doctors are usually asking 5 times a minute, where's the patient? That's all they care about.
Yeah.
So finally, outside of work, what keeps you inspired and passionate about what you do professionally? Hobbies, inspirations, what do you got?
I think this is going to surprise you a little bit, because when you wrote this question down, I was like thinking, do I talk about, I like hiking, I like outdoors, sports type things. But there's something that I'm going to divulge for you that you probably didn't know about me is I'm like an avid builder. And so I've actually flipped 4 houses at this point.
No way. That's awesome.
And so I love taking something old, dilapidated, or something that needs work.
Oh, so you actually do the work?
Well, I do some of the work, and I love the design phase. So sometimes I hire certain projects, and sometimes I do it myself. But what I've really gotten fascinated with is kind of building dream garages. And so I'm on my 3rd dream garage.
Very interesting.
Yeah.
What does that even mean? I mean, what is a dream garage? It's like a man cave or something?
It's kind of a little bit of both. So it's a place where you could hang out. It's a man cave. It certainly has a nice beer fridge.
Or a woman's cave, whatever.
It could be a women's cave.
Yeah.
But then it's also a fun place where it's got all the tools and like a really nice setup to just dabble on your car and kind of just, fix little things around your car. And I'm always trying to teach my 2 sons how to wrench. And I have this, relatively new Bronco. And every month I buy one little something for it that we have to bolt on. And we do it with my boys in our man cave garage. So,
that's awesome.
Now that I moved to Atlanta, I'm first building the garage, and then I'm going to kind of start to dabble with the car with my boys again. But it's just a fun space to do all of that.
That's awesome. That's great. Yeah, having hobbies and time away is so important for perspective, I think.
Absolutely.
So that's fantastic. Well, look, Zsolt, I'm really thankful you came on and agreed to do this with me. I'm looking forward to staying in touch with you in 2026. So this has been the 10th episode of Align Health Insights, and I really thank you very much for joining me. Bye, everyone. Until next time.
Thank you so much.